Okay, thank you, Laura. So I'm going to talk about trauma. We heard Alan in the previous talk about just thinking about trauma and complex health conditions. It's not something that's widely talked about, so I thought it might be interesting to talk about it today. Okay, so we're going to talk about trauma in the next half hour. We're going to talk about PTSD, the different types of trauma. Then we're going to look into PTSD in more detail and think about the effects of PTSD on our life. And there's a study called the ACEs study that I want to talk about because it's particularly relevant here. I'm going to then talk about how trauma works in the brain, and then think about the treatments for trauma, and then just give you a couple of case studies at the end. Okay, so different types of trauma. So if you look at the literature, trauma tends to be talked about in terms of big T trauma and little t trauma. Okay? In a sense, both of them can wreak havoc on our physical health, so they're both as important as each other, but there are some just minute differences that it might be useful for me to explain. Okay, so what kind of experiences or events tend to lead to trauma? And it tends to be an experience which has what we call the UDIN characteristics. And they are that the experience tends to be unexpected, happened out of the blue. It was very sudden. It tends to be dramatic. When we say dramatic, we mean something that's probably high emotional intensity. It tends to be isolating. So even if there were other people around, in that moment, I felt completely on my own. And lastly, the N is no strategy for coping. It was so unexpected and it's so big, I didn't know what to do. I didn't know how to respond. So when you have an experience with those characteristics, there's a tendency for that experience to lead to trauma. So what is trauma? So it starts with experience that causes high emotional arousal, and the emotions that tend to lend themselves to future trauma tend to be terror, horror, fear, disgust, shame, humiliation, and finally, embarrassment. Yeah? So these are emotions which often involve high emotional intensity. And later on, I'm going to tell you about how trauma works in the brain, and we'll understand why these sorts of emotions tend to lead to trauma. Okay, so big T trauma. So big T trauma are those big events that we've all heard of. So, and it could be a natural disaster like a tsunami, a man-made disaster like some of the terrorist attacks that we've experienced. It could be an accident like a road traffic accident, a physical assault, a robbery, a murder, a sexual assault, war. All these things are what we call big T traumas, and they're huge. But also we can be affected by little t traumas. And the distinction is little t traumas tend not to necessarily mean a threat to our physical life, but more kind of like a threat to our sense of self in a way that we feel devalued in some way. And again, these are experiences in which we feel that we cannot cope or we feel helpless. So little t traumas can be more frequent. But again, the impact of those frequent little t traumas can almost be exponential. And I'll talk about the ACEs study a bit later. And it can affect our self-esteem and foster what we call the inner critic. And again, we'll look at some case studies later. Okay, so little t trauma experiences could be things like infidelity, being shouted at, being bullied, relationship problems or a relationship ending, leaving a job, a divorce or legal issues. So you can see that they're not necessarily big T traumas, but actually they can still be quite impactful. Okay, so let's look into PTSD. So PTSD is a specific type of trauma. And we're just going to look into kind of like what distinguishes PTSD from trauma. So post-traumatic stress disorder, so it's classified in the DSM-5, which is the Diagnostic Statistical Manual for Mental Disorders. Really, you're looking at three broad criteria, which we'll look at in a bit more depth in a second. But the three criteria are, well, the first one is re-experiencing. Okay? So the re-experiencing tends to be intrusive thoughts or memories. And these could be in the form of like flashbacks or nightmares, or just reminders that bring back the memory. So that's one of the key criteria that distinguishes PTSD from trauma. And the other criteria are avoidance. You know, do we start avoiding things that remind us of the initial experience? And the third one is heightened arousal. You know, since that event, I'm just keyed up, I'm just anxious all the time, I'm snappy, I'm irritable, I'm frustrated. So in the presence of those three criteria, that's what we're looking at if we're going to start diagnosing someone with PTSD. Okay. So just to go into the criteria in more depth, one of the distinguishing factors that would distinguish PTSD from trauma is known as criterion A. And this is basically a threat to life, an experience that involves a threat to life or a threatened threat to life, or this could be a serious injury or sexual assault. Okay? And this could be done by direct exposure, that you experienced it yourself, or that you witnessed such an event, like you witnessed somebody perhaps being stabbed, or you learned, you heard in intricate detail about somebody close to you going through a traumatic experience, or it could be indirect exposure, such as first responders. So, the paramedic who arrives at a road traffic accident first and sees the carnage in front of them can develop PTSD. Okay, criterion B are the intrusive symptoms. So I just talked about the re-experiencing. So criterion B is tapping into that. And these are just unwanted, upsetting memories that keep coming back out of the blue when we least expect them to. This could be nightmares, flashbacks, an emotional distress when those memories come back, and just this physical reactivity, just feeling keyed up all the time. So and just one of those symptoms are needed to get a diagnosis of PTSD. Criterion C is avoidance. Are we starting to avoid things that remind us of the trauma? I mean, let's say I was walking down in New York and I passed a block and I had a big red wall in front of it. And then I got mugged and somebody took my wallet. And then back in London, I'm finding that every time I go past a red brick wall, I'm feeling really, really anxious. So actually, I start avoiding kind of like bricks. Why? Because actually, it's reminding me of the trauma and it's bringing back those intense symptoms. And then some other criteria that are needed are a worsening in mood. So am I feeling more anxious? Am I feeling more depressed? Am I feeling quite isolated? Am I withdrawing? And criterion E, and this always comes up, which is difficulty sleeping. When we are traumatized, when we have PTSD, actually a lot of people say it's difficult to sleep, particularly if you're getting some of the nightmares. And there's irritability and anger and a certain amount of hypervigilance. That's kind of like I'm on the lookout for any sort of threat or danger. And the last criteria is that the symptoms have to last for at least a month. And that's because if you experience a big event, you won't necessarily experience PTSD or trauma. And sometimes it can resolve itself naturally. But beyond a month, beyond 2 months, if these symptoms still persist, then it might be worth thinking about getting some trauma treatment. And I'll talk to you about those a bit later. Okay, so who gets PTSD? So it's approximately about 7 to 8% of the population will at some point in their lives experience PTSD. But of course, you have to have one of those qualifying events that we talked about, like a big T trauma event or a little T trauma event. So of the people who experience one of those qualifying events, between 10 and 37% will experience PTSD. On average, it's about 20%. But the number varies on whether it's a natural event, such as like a tsunami, or a man-made event, like a terrorist attack. So it seems to be higher. We're more likely to get PTSD if it was something like a man-made event. But interestingly, one of the risk factors that can increase the likelihood of people getting PTSD is having experienced the trauma in their childhood. So we're going to look further into that in a second. Okay, so this is the study that I mentioned at the beginning. And this is called the ACEs study. And the ACEs stands for Adverse Childhood Experiences Study. And so in the 90s in America, a company who, like a health organization called Kaiser Permanente, were really interested in this association between trauma and long-term health conditions. And so they did a study, and it was a big study. They managed to get 17,500 people involved in this study. That's a big study. And it was a simple study. It was just a survey. So people just had to tick whether they had experienced an adverse childhood event. So let's just have a look at what constituted an adverse childhood event. So if you had experienced as a child physical, emotional, sexual abuse, if you'd experienced physical or emotional neglect, if you had mum or dad had experienced psychological difficulties, if you had a parent with substance misuse problems such as drugs or alcohol, if one of your parents had served time in prison, if you'd experienced parental separation or divorce, or if you'd also been witness to domestic violence at home. So if you'd experienced one of those as a child, you would just tick if it was relevant to you. And every tick represented 1 point on the ACE questionnaire. So what did they find? So they were quite surprised because they said ACEs were common. Adverse childhood experiences were really common. In fact, over 2/3 of that 17,500 people had experienced at least one adverse childhood event. Okay? Now, 12%, which is quite a large percentage, 12% had experienced at least 4 adverse childhood experiences. And so they looked at how that was associated with future long-term health conditions, and they find that actually there was a really high positive correlation with the presence of a long-term health condition. So that is that if you'd experienced 4 or more adverse childhood events, you were much more likely to be experiencing future physical health problems. So what did they find? They found that there was between a 2.5% increase to a 12.5% increase if you'd experienced 4 or more childhood events of COPD, depression, hepatitis, suicidality, liver and digestive issues, lung cancer, and ischemic heart disease. Now that's a huge correlation. So they wanted to think about why. How can we explain this? Is it that they've just experienced a lot of misfortune in their childhood and they got involved in the wrong crowd and they started smoking and drinking and it was that had effect on their health? Or was there something else going on? And so they looked into it and they thought there's something else going on here. And what they found out, just from doing scans, MRI scans of the brain, etc., is that the stress that was caused by the adverse childhood event was having an effect on the developing brain and the developing body. And what we've understood is actually the brain is very, very sensitive, particularly to stress, particularly if it's kind of like chronic stress. And it was causing differences in the structure of the brain. The structures of the brain were not necessarily growing properly because of that stress. And they also found that actually, if we'd experienced some of those stressful events as a child, we were more primed to stressful events later. So this is why actually, if we've experienced traumatic events as a child, we're much more likely to get PTSD later because we're primed to it. The body has learnt. And in a sense, what we're learning is that the world is a dangerous place. I need to look out. And what they learned is that actually the stress that the child had actually affected the body's resilience and the body's capacity to look after itself and regulate itself and heal was affected by experiencing all those stressful events when we were young people. So we heard Alan talk about the elephant in the room. And actually, are we thinking, is trauma one of those elephants in the room that we've ignored, that we might need to think about when we're thinking about managing our long-term health condition? And if by resolving trauma, actually, can we experience more improvements? Is the body more likely to go into a healing state if we take it out of that stress fight or flight system? Okay. We've got this high-performance car, and it's just not going. Why is it not going? Actually, well, it's because there's an elephant in the room, and that could be trauma. And in some cases it is, in some cases it isn't. Okay, so how do we recover from trauma and PTSD? Okay, so really we're talking about trauma here. Seeking out support from other people, such as friends and family, that's really important. Finding a support group. Talking about these experiences. You hear lots of stories about people coming back from tours of duty, and they will not talk about their experience. And so in a sense, the trauma is kept inside and it's never resolved. Learning to feel good about our actions in the face of danger. Quite often one comes up as people who experience shame because they didn't act in a different way. Having positive coping strategies and being able to respond in the face of fear appropriately. So what's the thing about medication? So we know the NICE guidelines say when we've got PTSD specifically, the first line of treatment should be a trauma-focused therapy. And they say that actually medication should not be used as a first line of treatment. Because in a sense, when you're using medication to treat PTSD, it's more kind of like an anesthesia. You're just trying to mask the symptoms, but you're not necessarily resolving the PTSD. So we know the NICE guidelines are saying, actually, in the first event, we need to be using a trauma-focused therapy to clear this. And I'll tell you how the trauma-focused therapies work. So let's think about how trauma manifests itself in the brain. So here we have the brain. Okay, the brain is very complex, but we're going to just really simplify things here. So we have the thinking brain and the feeling brain. Okay? So at the front here, we've got the prefrontal cortex. This is the thinking brain. And then in the middle, we have the feeling brain. This is the limbic system. Okay? Now that structure there, that little red almond-shaped structure, is called the amygdala. And the amygdala will activate in the presence of strong emotion. So when we're talking about horror, disgust, shame, embarrassment, in the presence of those strong emotions, the amygdala activates. The amygdala is our body's alarm system. If the amygdala activates, that triggers the fight or flight system. Okay, there's a seahorse here because the hippocampus isn't actually, it looks a little bit like a seahorse. So the hippocampus, just for simplicity, is where we store our memories. Yeah? Okay. And then the third structure that I want to talk to you about is called the thalamus. The thalamus is like the relay station. So any experience that we have is routed through the thalamus. So we have a pathway from the thalamus to the amygdala, but we also have a pathway from the thalamus to the prefrontal cortex. Okay? So what happens is we experience an event, and it involves strong emotion. If it's strong emotion, the amygdala is activated. Now, as you can see, the pathway to the amygdala is a lot shorter than the pathway to the prefrontal cortex. Okay? On top of that, we know that the processes in the amygdala, in the feeling part of the system, work 40 times more quickly than the thinking brain. Okay? So as soon as we've experienced something that's involved strong emotion, the amygdala is activated, it's triggering fight or flight, and the pathway to the prefrontal cortex is cut. It's stopped. So why is it blocked? Well, it's blocked because this amygdala is there for our survival. And it's just thinking, actually, you do not need to spend mental resources processing this memory and then sending it back to the hippocampus to store. Okay? This event was so huge that actually I don't want this memory stored in the proper place, which is the hippocampus. I need to keep this memory current. So this memory is, if you like, it's stored in little memory capsules around the amygdala. These traumatic memories are not stored in the proper place, which should be the hippocampus. Why is that? Because the amygdala is just thinking, I'm here to look after you, to make sure that you're safe, okay? And I don't want to downplay the importance of these memories. So if I keep it current, if anything comes up in your life that's remotely similar to that traumatic event, I can trigger that fight or flight system quicker and then you can cope with the event or you can escape. Yeah? So it's there for our survival, but it's not necessarily there for our well-being, because when these traumatic memories are there, it's putting us in a state of anxiety and high alert. And actually, we don't do well as a species when we're constantly in that state of fight or flight. Yeah? It affects the system. The body doesn't heal itself in fight or flight. We want to take the body out of fight or flight, and that's when the body will start to heal itself. Okay. So any trauma therapy, and there are many, will be trying to do a number of things. What we need to do is revisit the memory, but in such a way where we're not re-traumatizing the individual. If we re-traumatize the individual, all that happens is the pathway to the prefrontal cortex is blocked, and the memory doesn't get processed and stored properly. So we need to revisit the memory in a way where the pathway to the prefrontal cortex remains open, the memory can be processed, stored in the proper way, so that we can recall the memory at will, but without the distress that we had. And we've got a lot of very good therapies that do that very effectively. So that's trauma in the brain. Let me just give you another example. So there's a traumatic event, such as a car crash. Okay? Now, in a sense, that event is not the problem. That's happened. That's in the past. That's gone. The problem is, we have a representation of that event. We have the memory of that event. And it's the memory of the event that's the problem. Not that it happened, but we have the memory of this event. And when we're doing trauma therapy, we're looking at two very important components. One is that when I think about the event, I get a lot of emotional distress. But the second is, I've got a very unhelpful negative belief about the event, which could be, I'm going to die. Now, logically, with our thinking brain, we can say, well, I know I didn't die, but for some reason, because that memory is stored in the wrong place in this memory capsule, it doesn't have access to that information because it's not got to the thinking part of the brain. So with our trauma therapies, we need to update this belief and reduce the distress. So if we can update the belief, reduce the distress, and in a sense, do a reappraisal, which was, I survived, then the memory becomes no longer traumatic. Yeah? I'm not saying the memory will ever be comfortable, but it shouldn't be anywhere near the emotional intensity that it is currently as a traumatic memory. Okay, so some of the trauma treatments. So these are just a few. So CBT, EMDR, which is eye movement desensitization reprocessing, and emotional freedom technique tend to be my choices in resolving traumatic memories. And I mainly use EMDR and EFT just because I find them more quick and effective than CBT. Okay, so with CBT, the idea, it's a talking therapy, and I'll talk about that when we do the presentation of talking therapies. It involves stepping into the memory, reliving the memory, and identifying the worst moments of that memory, identifying the negative beliefs that we had. I thought I was going to die. I almost died. Updating those to actually I survived, and then reliving the memory with those updates. And again, that tends to be very effective in terms of resolving trauma. So EMDR, this is quite a weird one. So it's using bilateral stimulation, either eye movements, or it could be auditory beats, or it could be tapping. And what you're trying to do is evoke both hemispheres of the brain to aid the processing. They don't know why it works, but they know it works. They think it mimics our dreamlike state, our REM sleep, when our eyes are flickering. Yeah? They don't know why our eyes flicker, but they think it's because we're processing emotional information. So that's a little bit about EMDR. It's the gold standard for trauma therapy. And lastly, we've got EFT as well, which is you're tapping acupuncture points around the brain. And that's really effective because, I can do this with people over Skype. I finished with a client last week. She had a couple of trauma memories about the birth of her son. And, 4 or 5 sessions over Skype and the trauma was gone. So EFT is also very effective. Okay, so I'm going to spend 1 last minute just talking about these case studies. So in the context of EDS, I had a client, 31, EDS, pain fatigue, but her traumatic memories, and I think this was PTSD, were around 2 hip dislocations. Okay? She had a night. So the first one, she had a hip dislocation, and it took 2 hours for the ambulance to come. No one knew what happened, but she knew she was in extreme pain and just didn't know how to deal with it. So this one, we used EMDR. Used EMDR, 4 or 5 sessions, and she'd resolved. But actually, she still had some nervousness about kind of like walking and bumping into people. So we were able just to think about actually her anticipation. So using EMDR, we worked on her anticipation. So her anxiety about actually going out and doing the things that she used to do was very much diminished. And lastly, we have Pamela, so 22, and her traumatic memories were first collapsing, having no idea why, didn't have a diagnosis of EDS at university. She had a traumatic memory of receiving the diagnosis and then of a subsequent surgery. And for this one, we used EFT, an advanced EFT technique called matrix re-imprinting. And we used that, and again, I think that was 4 or 5 sessions, and we'd resolved the trauma. Okay? So, thank you for listening, and I'm around for a few minutes to take some questions.
Okay, so if anyone in the room has questions, if they could move to the microphones, please. I'm going to read some of the questions that have come in through the app, so bear with me. For those that are questioning how they do that, if you go onto the app here, and if you click on Agenda, and if you click on the topic like that, you'll see that there's an option to write a comment, and that's how you write your question there. So that it updates live. So if anyone has questions and they don't want to go to the mic, then you can do that. Okay. Has the theory that general instability in the body in EDS and therefore continuous stress and the switched on brain functions, is it known to cause an unknown basis for anxiety?
So I think there's 2 elements to this. I think the question may be pulling out the difference between joint instability and joint hypermobility. They are subtly but importantly different things. Many people have unstable joints, which leads to issues with control, with ease of injury, etc. In what might be a hypermobile or a non-hypermobile joint. At the moment, we focus a lot of our description of hypermobility diseases on the hypermobility, but in clinical practice, we recognize the instability and the ease of injury as probably one of the main components, one of the main issues. If you then take the risk of injury, micro trauma to the joints, major trauma to the joints, the story of the hip dislocation is an example of the ultimate in instability. You can begin to see how these sorts of issues might lead to triggers that cause autonomic rise in concern, which can be fear and distress, which can push towards the development of anxiety and other elements that you've just been describing if it's particularly traumatic, and therefore start to lead to a state of anxiety. If that anxiety is extremely profound and having quite a large impact on life, then you are developing, by definition, an anxiety disorder. Mm-hmm. So maybe that's one pathway. There are probably many, many more. But the importance behind listening to the story and trying to work out what's been going on is to not start at the anxiety disorder, but to assume that you just basically treat the anxiety. What you have to do is you have to work back from the anxiety disorder and forwards from the original events and try and get a picture of the history, the pattern, the change over time. We are beginning to conceive of the idea that this sort of wind-up of all of these events, all these different things happening in the body, is biologically not good for anybody. The more traumatic events you have, whether they be physical in relation to, whether they be environmental, whether they be social, whether they be psychological, the more you're going to develop concerns that might lead to anxiety-type disorders.
Mm-hmm. Thank you. Is there an explanation why some people with the EDS experience the opposite of anxiety? So, for example, becoming extremely resilient to the point of self-neglect?
This is really interesting, actually, because, the world of pain has sort of come to this conclusion that sometimes it's really bad to feel that you're in control of your pain by using all of these mechanisms to suppress everything, because as soon as you suppress all these things and feel like you're more in control, the potential might be that actually you're out of control. I might hand over to you in a moment to explain that further, but yes, of course it's really important to be able to find ways of building resilience. But actually, if you find yourself in a situation where you are so controlling everything and trying to be so on top of everything, I think that can be a mountain in itself, just being able to manage. Your thoughts?
It's, when adverse events happen, sometimes you can get two different people, two completely different reactions to that adverse event. So one is to perhaps overdo things in an effort to regain control. And another response could be actually just to let things go, to kind of like give up. And when that comes up in my clinic, the word that I'm thinking of is acceptance. There's an issue around acceptance, and I'm going to talk a little bit about acceptance a bit later on in the talking therapy section. And I'm going to talk about it in relevance to a case study as well, so that'll be quite interesting to listen to. But if that comes up, that's a barrier to successful management of the health condition. So then we'd have to explore acceptance. I had a client like last week, and she has diabetes, and she was so overwhelmed with everything that she had to do to manage the diabetes that she just stopped doing it. She just gave up. She couldn't do it. So she wasn't anxious. She did have low mood, but again, we had to accept. We had to address the acceptance. Yeah.
I'm minded of another story during one of our echo sessions a couple of weeks ago, where a case was presented of a lady who, in all aspects of her life, had immense amounts of control. And you'd think when you looked at the story that actually she was just terribly, terribly organised. But actually, when you unpicked what was going on, she was deliberately making absolutely sure that very specific things were happening during the day, at particular times of the day, her relationship with her family, her relationship with herself and her condition, that actually it was so tightly controlled that the process of the control was the problem, and was becoming a huge problem for her. And it was a fascinating story to hear. Now that's extreme, but we all fall into those realms of trying to be in control of something, where in fact actually what's happening is it's a mechanism to almost deny the fact that it's still controlling you.
Thank you. Faye. No.
Good morning. My name's Patricia Hewitt. I live in the Scottish Borders. My youngest son, who's 22 now, was diagnosed with hypermobility, aged 18. I find the whole lot fascinating in a way, because he was diagnosed at 17 with Asperger's. He was then diagnosed with ADHD when he was young. He now has attention deficit disorder. And I am busy petitioning Parliament again at Holyrood over pathological demand avoidance. He has that. He was written off as lazy and winging it. I have been bullied, threatened, lied to from the highest, from First Minister down over. Who's covered up the truth? It beggars belief. He is actually a cellist. I hate to say men are good, it's against every principle in my body, but this tutor who listened to the horror story at Edinburgh College, because we're now using the right strategies, he's now gone through, he's now doing a Bachelor of Music. The issue is, he's a cellist. And of course, trying to explain to people how much the hypermobility affects the other issues, because the anxiety is off the scale with the pathological demand avoidance. And we have recently added on significant sensory processing disorder. And, just trying to get help, support, And being very diplomatic, the rheumatologists report, I apologised when I handed this in. It was just an absolute disgrace. The lack of understanding generally of how much autism spectrum disorder and issues like this, the amount of children who aren't recognised with these issues, and also the amount of parents who are now saying, I've got fibro, I've got this, I've got that. And it's how to help, and, you know, where do we go? It's like a backward area up here, and I've had to pay privately for a diagnosis from a 22-year-old. My 23-year-old, who's extremely bright and clever and was expected to go to Oxford, Cambridge, St Andrews, and now spend his life on benefits. The other things, talking about traumatic, the dad was on a heart transplant list for 5 years and died of misdiagnosed cancer of the stomach. So what you've been talking about this morning, how the neurodevelopmental issues overlap, but getting people to believe you and understand, it's just a nightmare.
So thank you so much for sharing that with us. It's obviously a story that completely resonates with many, many people, and it totally resonates with us and our experience. And I think the only way I can really answer it for you in the broadest sense, without a personal exploration of how we can help with advocacy, is that that's the reason for being here today as a group. That's the reason for having this open conversation and for the world starting to listen and to watch. Do I believe that tomorrow there'll suddenly be a service that's set up somewhere in Scotland or anywhere in the United Kingdom that's going to get this right? No. But the more we get people to understand this at a clinical level, the more we're able to help with resources. But also, the more we support each other and understand it between us and know how to advocate for each other, the more fighting chance we have. I don't know where you are on your personal journey, but I do know other people who've had exactly the same experiences who are further on and in better places, but they have all battled to get to where they are. And so the more we're able to share this, identify ways to support, encourage new resources, the better. So thank you so much for that really powerful story.
What is the percentage of reoccurrence of trauma or PTSD after therapy?
Okay, so it depends on how successful the therapy is. I would say if the therapy was successful, and with trauma therapy, it kind of should be. You kind of know if it's dealt with. If you've completely resolved the trauma and you check that out at the end, then it's extremely unlikely for that particular event to cause problems again. Now, there might be, if a very similar event happens again, so let's say, I don't know, you were involved in a terrorist attack, you had some PTSD, which was successfully resolved, and then you were involved in another terrorist attack, there is a possibility that you could be re-traumatized and that could come up again. But it's so unlikely, it's probably not worth thinking about. But there is a possibility that you could experience another type of trauma, in which case then, if that develops into PTSD or the problems persist more than a month, then it might well be necessary to have further treatment to resolve the trauma. But for the trauma that you've worked on, it's very unlikely that that will be a problem again.
Is the severity... Sorry. Okay, yes. Press the yellow button for us. Thank you.
Hi, my name's Kate Murdoch, and I'd just like to... good morning, Dr. Hakim, and good morning, Dr. Shepherd. Myself, I know it's been a hard journey. I've got 2 children, a 7 and 8-year-old. Looking at all of your ACE study and that, I think the main question there is how we can help recognise these families that they are going through the post-traumatic stress for what they have been through. I see myself, I've worked myself very hard through trying to counsel myself to be able to speak here today, to be able to have that confidence, to be able to speak and not get anxious over the situations that we've been through. But it's more on how to help these families, because knowing that you know, it is going down generations, and it is a lot of trauma in their backgrounds, which then parental, and as you were saying about later on, about the effects on the children's brains and everything like that.
Yeah, I mean, it's a really difficult topic, but I think, you know, forums such as this, I think, you know, the people suffering it and identifying that their child was perhaps traumatized and might need some help speaking about it, and again, as Alan pointed out, battling with services. For us professionals, finding the forum to speak, you know, we also meet other services like CAM services or adult psychology services, where we're talking about the extent of trauma and hypermobility. The fact that this event is being live streamed out to people. I mean, gradually the message will get across, but it's going to take a while. But you can even think about the political agenda. You know, there's not enough money being put into children's services, really. So, of course, the pressure on CAM services to treat children is extremely limited. And so we might even want to think politically about, you know, which political party is going to do more for children's services than is perhaps happening at the moment.
I think a parent, because I contacted Dr. Hakim myself earlier on in the year in that heightened state, and I've managed to heal myself and bring myself to a more mindful state where I can actually control everything that's going on in my body. And how do we teach our children to be able to recognise? How do we teach our children to be able to recognise the resources and be able to contact these professionals when we are in this heightened state? That was my question. I'm very sorry.
Yeah. So for me, it's I don't know where you live or what the services are like, but it would be going repeatedly back to the GP, trying to get a referral to the children and adolescent mental health services, if you can. It's very difficult when you're in a heightened state, and what we'd say is actually you have to work on yourself first before you're then in the position where you can then help your children. And so what you've done on yourself is absolutely fantastic. But again, it's contacting the services. And I know as part of the Ehlers-Danlos Society, there's a whole section for children. So I don't know if your children do have hypermobility issues.
Yes, they both do have hypermobility issues, but we're waiting for an NHS diagnosis. So.
Oh, okay. But again, there's a section of the Ehlers-Danlos Society, the junior zebras, and there's a lot of resources there, you know, in terms of, you know, perhaps educating your children and helping your children come to terms with and manage, you know, some of these symptoms.
I think the other thing is that we all completely recognise the limitations on resources within the health service, within social services, and you know, perhaps one of the biggest opportunities that we all have as a collective community is to work out how best to provide advocacy, maybe through, you know, our organisations, through voluntary support, as providing as much information and support as we can within our own community, because we probably understand it more than anybody else does, and the changes in the resources that you might need to have helped you with that acute episode that you were having are not realistically going to be there in a short space of time. They might come at some point, but right now, I think this is about our whole community being able to have, you know, honest, helpful, open conversations and be supportive about the fact that these very issues are absolutely real for so many people. So advocacy within our community and helplines and those sorts of support are another way that we can try and support each other.
Yeah. So we have to leave it there. I'm sorry that I know there's questions in the room, but I think Dr. Hakim, Dr. Shepherd would hang around here for a few minutes for people that wanted to ask questions directly. We now have a break. We need to stick to time, so if everyone could be back here at 10:45 sharp when we'll begin. Thank you all. Thank you to our speakers.